Okay, first topic. Layers of skin, cells of epidermis. Layers of skin, epidermis, dermis, hypodermis. Maybe let's look at the accessory skin structure to make sure that you will not confuse them and you don't tell me later that sebaceous glands or whatever are part of the skin structure, or you tell me that dermis or epidermis is part of the accessory skin structures. So, skin structure are about skin layers. You have epidermis, dermis, and hypodermis. Accessory skin structures are about sebaceous glands, sweat glands, hair follicles, and that stuff. You have, you know what, let's skip altogether the topic number 3. That topic is about for you to know what is the difference between sebaceous glands and sebaceous follicles, eccrine and apocrine glands. Just cross it out.
Is it going on a test?
No, it's not going to be on but so we can go to the next topic right now. So disorders, because for skin, just remember layers, accessory structures. Oh, cells. What are the most abundant cells in skin?
Keratinocytes.
Yeah, keratinocytes, 90%. What else do you have? What cells? Melanocytes. And what happens with melanocytes if you are exposed to UV radiation?
Darken.
What do they do? No, think about what melanocytes do if you are exposed yourself to a lot of UV radiation.
They protect the nuclei.
How?
By wrapping it around, they're on the top.
Wrapping around what? What do they do? What is their function?
I ain't got a lot of time.
They're
Tom,
the
just
sunny
tell us.
side up.
Yeah, but what is accumulate around that sunny side?
The protector.
Surfactant.
What? Not function.
Melanin.
Meaning, function of keratinocytes is to make keratin. Function of melanocytes is to make melanin. So what do those melanocytes do if they are exposed to a lot of UV radiation? They start to produce a lot of melanin. This is why you get brown if you expose yourself to the UV radiation. And this is what accumulates around that sunny side of nuclei, melanin, the granules of melanin. And so, exposure to UV radiation will make your melanocytes produce more melanin. They will not increase in number. They will just produce more melanin. So this is what you need to remember about skin.
I know, that's one.
Disorders. Inflammatory and papillosquamous. Inflammatory are those which are about a lot of inflammation. Papillosquamous disorders, you can have inflammation, but you also have scales. Dry scales. Allergic contact dermatitis, irritant contact dermatitis. Okay, this is a contact situation. The manifestations are just local. And those manifestations are about what? Red skin, erythema, itching, meaning pruritus. Tiny blisters are possible, meaning vesicular lesions in both situations. Just that one situation is due to allergens and the other is due to many other things you are exposed to for a long time. You don't have to be exposed to allergen for a long time. If you are allergic to something, you are exposed and you have manifestations. The contact dermatitis is about exposure, contact for a long time. Acne vulgaris and acne rosacea, how different they are? Acne vulgaris for population? Teenagers. Rosacea?
40 and over.
Yes, middle age adults. Location of acne rosacea?
Your face.
Yes, the middle third of your face. Location of acne vulgaris? Face, neck, especially. And for acne vulgaris, what causes acne vulgaris?
Hormone.
Plugs.
Sebaceous follicles. Sebaceous follicles. And overproduction of sebum and obstruction of those follicles by sebum. For acne rosacea, this is about inflammation of those follicles. It's not overproduction and blockage of those glands and follicles. So it's a little bit different. Rhinofiber was what?
The big nose.
Yeah.
Yeah, red, big, inflamed tissue, edema.
Inflammation and involvement
Atopic dermatitis, papillary squamous. If you have that scaly, dry skin. Okay, I don't think you are going to have any questions about that.
But what?
Also about this.
Don't hold out on us.
Just see what is here. Yeah, let's look at skin infections. We are going to have just 8 of those questions. So, skin infections could be either bacterial, viral, or fungal, right? All those pathogens could be involved. What are furuncles? Boils. Related to what accessory structures of skin?
Hair follicle.
Hair follicles. How different carbuncles are from furuncles?
One's multiple.
Yeah, more than one hair
A
follicle.
carbuncle.
Systemic manifestations possible, which you don't have usually in case of furuncle. Okay, herpes virus infections. This is the viral type of infections. Herpes, okay, we know about the type 1, type 2, one causes cold sores, the other is genital herpes. And you know that this is about viruses, which once you are infected, they will stay with you forever. They will wake up from time to time and cause those blisters to form. Fungal, Candida albicans, infections. What population will you most commonly affect?
The dirty one.
Very young children
Corticosteroid.
which don't have the immune system fully developed, and those which have disease of affecting the immune system. Skin cancer, flush, yeah, is a superficial albicans, C. albicans infection, commonly seen in infants. So thrush is superficial, C. albicans infections commonly seen in infants. Skin cancer, which one is the most common one?
Basal cell.
Basal cell carcinoma. The second most common?
Squamous cell.
Squamous cell carcinoma. Which one is more dangerous? Squamous. Because of what? Produces metastasis. And the basal, not of malignant melanoma, the most dangerous, you know the ABCD rules, you know that metastasis are developing early, and this is the list. Those other two basal and squamous are most common, but the malignant is about the highest number of deaths due to skin cancer. We are done with skin.
Okay, urinary.
Urinary system, we have just done it 2 weeks ago.
Okay.
Normal number of questions, meaning about 15. Skin, just 8, and musculoskeletal system, the last one, 6 questions.
I'm gonna have to write that down there.
So,
And it's 115
Getting.
about the same amount you will have in relation to other systems.
And it's
Approximately.
100 questions.
100 questions total. And you remember that each new topic is started with true false questions.
Just as long as there's no fill in the blank.
There's no short answer question.
15
So, do you want urinary system?
Yeah.
If you don't want, you just go home.
No.
Who wants urinary system?
I
Just
want
pay for
this.
it.
Yes. I want to get the whole thing.
Yeah, I can.
Here.
Go.
So
Kidney.
No, I'm not coming by.
we found out it's not mandatory.
I ain't got many bars.
Okay. Urinary system. Kidneys, major functions, internal anatomy, blood supply. Okay, for kidney function, remember that this is not just about blood filtration and urine selection. Kidneys are also endocrine organs because they produce EPO and they produce renin. So this is a major important function and people tend to forget that function. And then urine production, blood filtration means this is getting rid of urea, uric acid, creatinine, products of protein metabolism. This is about getting excess of ions out, whatever you don't need, whatever is above the homeostatic level, you get it out with urine. This is a way to get out hydrogen ions, so you will not get into acidosis. So this is about the kidney function. Internal anatomy, okay, what do we have? We have 3 layers. Again, do not confuse layers with the regions. Layers are about fibrous capsule, renal capsule. This is the first layer sticking to the kidney. Then you have adipose capsule, a fat layer. And then you have your fascia. This is that connective tissue, fibrous connective tissue, attaching kidney to surrounding organs and stays in place. So those are the layers. Directly underneath, and what about our quiz? We have questions related to that. Fibrous capsule, if you go from outside, you have fibrous capsule, adipose tissue is the middle one. And then you have your renal capsule. Renal capsule, actually, fascia is also fibrous connective tissue, but we call it the renal fascia. The first sticking to kidney layer of tissue is also connective tissue, but this one is described as renal capsule, not as fascia, renal capsule. What about regions? What is the first one directly under the renal capsule? Cortex. What is inside of the cortex? What makes cortex? Nephrons. What part of nephrons, especially? Cortex is the location of all what? What is the structure of the nephron? Because this is the next one of the next. Nephron, you have what? Renal corpuscle and renal tubules. Renal what part is about filtration? Renal corpuscle, meaning glomerulus and Bowman's capsule. What is glomerulus? Is that not like cluster of capillaries inside of Bowman's capsule. Okay, so all those corpuscles are located in cortex. Some of those convoluted tubules, parts of that part of those renal tubules which are convoluted, not straight. But if you have a question, remember we talked about that. If there is a damage to renal cortex, that would be about a damage to what? Renal corpuscles, because they are all there. And what would be affected? Filtration, especially. Filtration, because it takes part in those renal corpuscles. So, cortex. Then you have pyramids. Pyramids is medulla. Medulla is about pyramids and renal columns. And pyramids have striated, they look striated. What is the major component of those pyramids? Collecting ducts. Collecting ducts. So if we start, we can do it later. Because that would be one of those questions. Cortex, medulla, and the next major region? Pelvis. So we had tissue layers, now we talked about the regions. Blood supply, remember what I told you, you don't have to know names of all those branches of renal artery. you have to know that there is a renal artery supplying blood to kidneys and that it originates from the aorta, that by entering the kidney it splits into smaller and smaller branches. The smallest arteries are what? Arterioles, and we have names for two kinds of those arterioles. We have a name for that arteriole which goes into the Bowman's capsule, and this is the afferent arteriole. It gives the blood into the glomerulus for filtration, and after filtration the blood goes out and use another arteriole, and this is your efferent. E for exit. This is what you need to know about blood supply to kidney. Renal artery, branches, arterioles, afferent for blood supply into the place of filtration, which is the renal corpuscle, efferent to take that blood out of that renal corpuscle. One more thing to remember, efferent arteriole splits into another set of capillaries. How do we call those capillaries? Peritubular capillaries. What do we need them for? Remember, urine production is about filtration, absorption, secretion. So a lot of stuff has to be reabsorbed back into the circulation. Some stuff is still secreted out of blood circulation into the renal tubules. So this is the blood supply to the kidneys. We need to remember. You know, so once again, you know what renal corpuscle is about? What is the structure of renal corpuscle?
Oh, the tubules?
Not nephron. Nephron is about tubules. Renal corpuscle and renal tubules are part of nephron. So renal corpuscle is also about something. Bowman's capsule, and what is inside? Glomerulus. This is that. Those are the capillaries in which your afferent arteriole splits. Structure of the filtration membrane. This is our coffee filter, remember? This is how filtration membrane works. Coffee filter, grounds, coffee grounds stay behind. What in case of our filtration, renal filtration membrane stays behind in blood circulation?
The large
blood cells and plasma proteins. This is what you don't have in your urine if your kidneys are healthy. What makes that filtration membrane? Wall of the capillary, wall of the glomerulus sitting in the Bowman's capsule. Lamina densa, which is a little bit of that sticky fluid produced by cells. And then you have that special type of cells. You have your podocytes. And they have feet, and they surround the capillaries, the glomeruli capillaries, but not entirely. They leave the tiny openings, filtration slits. This is your filtration membrane. Process of your information, filtration, absorption, secretion. What is filtrate about? What do you have in filtrate? It is easy to remember if you know what you are not supposed to have in that filtrate and what you are not supposed to have. Blood cells and plasma proteins, everything goes in, meaning nutrients, meaning vitamins, meaning minerals, water, obviously. So a lot of good stuff goes into that filtrate. What happens to that filtrate? It goes out of the Bowman's capsule into, how do we call the first part of the renal tubules? Proximal convoluted tubules. They are proximal because they are the first part attached to that corpuscle. What happens in proximal convoluted tubules? We have to absorb all that stuff we don't need to lose. Don't want to. We mustn't lose them. Meaning what? All nutrients are reabsorbed. Do you have glucose in your urine if you don't have diabetes mellitus? No. So look, glucose has to be absorbed. Most of amino acids and lipids, and like I said, the vitamins, minerals, water, it will be reabsorbed. Reabsorption of water and some minerals, some electrolytes happens in the second part of the renal tubules. What is the second part of renal tubules? this one, loop of Henle. And then you have the last part of renal tubulus. This is your distal convoluted tubule. Distal, the DCT. What happens in there? Secretion. You want to secrete out of the blood circulation, or possibly there are poisons, toxins, drug metabolites, whatever is not supposed to be there in any amount. So this is about filtration, absorption, and secretion. Now, you made urine. What place of that nephron contains already urine? Obviously not renal corpuscle. What about the proximal convoluted tubule? No. What about the loop of Henle? No, because still absorption is taking place, and not distal, the first part, because secretion still is going on, but the very last part of distal convoluted tubule, that part which connects to what? Collecting tubules. Collecting tubules. It's also already about urine. What is the best estimate of functioning renal tissue? Yes. You know the definition, right? This is the amount of filtrate produced in 1 minute by all nephron present in body tissues. And it is the best estimate because damaged nephrons will decrease your filtration rate. The more damaged kidney tissue, the lower your filtration rate. And kidney failure, if your GFR goes below what? Yeah, then you have kidney failure. And why is that dangerous? Because what happens if you don't filtrate blood? Accumulation of all those substances which are supposed to go out. Okay, as glomerular filtration rate increases, what happens to the level of BUN, the blood urea nitrogen? Think about that. As glomerular filtration rate decreases. Absolutely, because you don't remove it. So BUN will increase. This is what is one of manifestations of kidney failure. What is oliguria? No, not absence. Inuria is absence. Inuria. Oliguria is decreased volume of urine being produced. Polyuria is poly, more. Number 9, we talked about that. Now all steps in recollection and emission. Okay, maybe not all. So we started with the Bowman's capsule, glomerulus, proximal convoluted tubule. This is number 9. Loop of Henle, distal convoluted tubule, and collecting tubules. Collecting tubules open into what kidney structure? Minor calyces. Minor calyces. And that opening is situated on which kidney structure? Openings of collecting tubules, ducts. They are situated, located on what kidney structure? Renal papilla. Renal papilla. Remember those pyramids? And on the end is structure we describe as renal papilla, and there are those openings for collecting ducts to release urine into the minor calyces. What happens to minor calyces? They merge and they produce major calyces. And what happened to the major calyces? They merge and make what? Renal pelvis. A renal pelvis is continuous with what? Ureter. And ureter takes that urine to urinary bladder. And urinary bladder, from urinary bladder via the urethra to the outside. I think if you have any question about it, you will just recognize those terms.
I thought we weren't even doing
to make sense out of that. If you have calyces, then you know that the minor are before the major. And you know that pelvis is that cavity which collects that urine and gets it into the ureters. And then you have bladder, and then you have urethra. Kidney disorders. They are often classified as those which affect glomeruli, those which affect renal tubules, and those which affect the blood supply, the blood circulation, renal blood circulation, renal blood vessels. You know the difference between the azotemia and uremia. There was a question on your quiz yesterday. So, azotemia is about what? Moderate increase in those nitrogenous products. Urea, uric acid, creatinine. Moderate. And you don't have manifestations. Uremia, kidney damage progresses. Accumulation of those products, there will be more and more and more of them, and eventually you will have manifestations of uremia. So this is the difference between the azotemia and uremia. And what is the difference between nephritic syndrome and nephrotic syndrome? Major manifestation is about amount of proteins in the urine. What is about amount of proteins for nephritic syndrome? Which one has more proteins in urine?
Nephrotic.
Nephrotic. More than what number? 3.5. 3 is that safe number. If it goes above 3.5, then definitely something is not good. What else? Nephritic syndrome is about inflammation, glomerular inflammation. Due to streptococcus infection. Nephrotic syndrome is about the minimal change disease. Okay, nephrotic syndrome.
Wait, so inflammation, you said stress?
Nephritic inflammation of the glomeruli. And then you have filtration rate being affected, so GFR goes down. Nephrotic syndrome is different because you have a damage to filtration membrane in such a way that that filtration membrane let a lot of proteins move into the urine. A lot, not like in nephritic syndrome, some of the proteins are able to move. And what did I want to tell you about that? For nephrotic syndrome, you will also have another manifestations which you don't have in nephritic. Problems with lipid metabolism, hyperlipidemia as possible. And so hyperlipidemia, then lipiduria. You have a lot of lipids in your blood circulation, you will secrete some of those lipids in your urine.
And that's nephrotic.
Urea, nephrotic. Nephrotic, a lot of proteins go out. You have lipid metabolism being affected. You have calcium metabolism being affected. You can have hypocalcemia, problems with your bones. Kalima, do you have a question?
Yes, nephrotic, you're saying there's some protein, but nephritic?
No, the other way around. Nephrotic is damage to the filtration membrane in such a way that a lot of proteins will be secreted out into the urine.
Nephrotic.
Nephrotic.
Did you say hyper?
Hyperlipidemia leading to lipiduria. Urea describing things present in your urine, like glycosuria. This is lipiduria. This is what lipids in the urine. And hypocalcemia. Because calcium is not absorbed as it's supposed to out of the digestive system. Nephritic syndrome is also, remember what I told you about nephritic syndrome? This is about inflammation of those capillaries. Inflammation is about a lot of inflammatory cells that stuffed with inflammatory cell capillaries, meaning slower blood flow because there's so much stuff that blood cannot flow as usual. And this is why filtration rate goes down. And that inflammation allows red blood cells to move in your urine. So you will have also red blood cells in urine. You don't have it in nephrotic syndrome. But like I said, the major difference is amount of proteins. Nephrotic, a lot. Nephritic, always below 3 grams. That heavy proteinuria will cause what in blood? Hyperalbuminemia. Remember? You lose a lot of proteins, so you have fewer of those proteins present in your blood. So hyperalbuminemia. And hyperalbuminemia will be about development of what? What about edema and ascites? Edema and ascites. Peripheral edema, ascites. You lose a lot of proteins. Function of plasma proteins, we did it yesterday. What is the function of albumins?
Oncotic.
To create the oncotic pressure, which is needed for what? To reabsorb water out of your tissues back into your circulation. So if you have proteinuria, you lose proteins, you have less in your blood, you have hyperalbuminemia, your oncotic pressure goes down, meaning less blood will go back into your circulation. More stays behind. This is what edema is about.
Can I ask one question real fast?
Sure.
Azotemia has no clinical symptoms.
No. In general, I wouldn't say no. Because it happens that people who have azotemia, they are like on the border between the azotemia and uremia. They can start to have some manifestations already. And remember that actually azotemia and uremia are those two terms which are very often used interchangeably. But uremia always indicate renal failure already. Azotemia, not yet.
All right, thank you. That's all I wanted. Good.
Acute versus chronic glomerulonephritis. Acute is about nephrotic syndrome. Chronic is about nephrotic syndrome. You know a manifestation for nephritic and for nephrotic, so you know manifestation for acute and chronic. What is the acute tubular necrosis? This is the necrosis of epithelial cells forming the renal tubules. Renal tubules are made of epithelial cells. So, necrosis of those cells is what tubular necrosis is called, acute tubular necrosis. Those epithelial cells. There are many different causes, sometimes seen post-surgery. UTA, okay. You're good with that, right?
Yep.
What are the most common renal stones? Structure? How would you distinguish? At least, would you have an idea that an inflammation, urinary tract inflammation, is just about your urethra or your bladder, and is not about your pelvis, which we would then talk about pyelonephritis. So how would you, what would help you to have an idea that your patient does not have a pyelonephritis, that could be just a plain
One's
urethritis?
upper, one's lower.
No flanking?
No, you examine your patient and you would do one single thing in order to make sure that that sign is present or not.
Yeah, flanking.
What about flank pain? Good, I haven't heard it. Good for you.
I got that on the record.
Time for class is over. Unless I will see you next year, once again.
And you're going to pass us all, so you don't see us again.
You don't like me that much.
will try not.
Oh, well, tortuous.
Do you have that question about hydroureter and hydronephrosis?
Yeah.
For hydroureter, just know this is abnormal enlargement of the ureter due to some type of blockage, urine accumulation above the blockage. Say that again? Hydroureter is an abnormal enlargement of the ureter. Can be caused, usually is, by some kind of blockage or narrowing of the ureter, causing urine accumulation above that blockage, and then pressure increases, and that pressure can increase in your pelvis, in your medulla, in your cortex, damaging those structures. So hydroureter is usually inherited problem, and it leads to death of one kidney, but the other kidney usually takes over, and it's not a problem usually, unless the other one gets to be infected. Hydronephrosis is dilation of the renal pelvis and calyces, because there will be accumulation of fluid, fluid, like up of urine moving up in that renal pelvis into those calyces and causing hydronephrosis, which could be due to that blockage of the ureter.
So you said it's backup of urine and it's a blockage?
It's abnormal dilation, expansion, due to the presence of urine, fluid with the, in general, urine is a fluid, in the renal pelvis and calyces. And of course that pressure will eventually damage the kidney structure. We are done with this part. I will tell you only what to do about the, we didn't just, what to pay attention to in case of musculoskeletal system.
Would you describe renal columns?
Renal columns are just parts of cortex invaginated.
You're not going to test on that, don't worry.
I don't think so. But I don't remember.
Yes, you do.
And you're supposed to know that stuff. Who is supposed to know it?
Sorry, musculoskeletal. What do we need to know?
Musculoskeletal, types of fractures, complete versus incomplete. Easy, right?
Okay.
Done.
Then classification depending on the fracture line. So you have all those different possibilities: transverse, oblique, spiral. And then classification into pathologic and stress fractures. You remember the difference between pathologic? A fraction due to bone tumor would be which one? Pathologic. Fraction in a joker who that jogs for several hours. Stress. Metabolic.
She said jogger, not joker.
For osteoporosis, definitely you want to remember that this is about bone resorption which exceeds the bone formation. So the outcome is what? Those porous bones.
First X.
And you know the population involved.
Old chicks.
Location of typical fracture. Don't put it as an S. That wouldn't give you any point extra.
That would get you a point taken away from me.
I will give you one. Okay, osteomalacia. How osteomalacia is different from osteoporosis. So you know this is about vitamin D deficiency, calcium not being absorbed. Tumors, you know, there's osteogenic, which has a poor prognosis, chondrosarcoma, the better prognosis, myeloma, which we talk about, talking about the blood disorders, immune system,
Bless.
Osteophytes are seen in which type of degenerative joint disease? Osteoarthritis or rheumatoid arthritis? Osteophytes. Haberdan, Nordstars, Bushard. Osteoarthritis. And you know the difference between in manifestations, we talk about justice today.
Nope, tell me.
That's it.
Okay, good.
Okay, what about Monday?
We don't need
Do you
it.
want just to have a day off to study on your own, or you need anything? Do you have enough of the reviews already? Is there
Enough
anybody
abuse?
who would like to do anything on Monday involving me?
You can come have lunch.
Spare you for 2 points.
If you decide otherwise, maybe we will just eat here. Otherwise, Tuesday, 12:30, 2 hours.
Okay, thank you.
You are welcome.
Taylor, she said 12:30, right?
No, we don't.
I feel bad for her.
For who?
Do we have to come to that one? I wish I had sit there. People miss I know. Thank you. You again.
I see you. Wrong power cord. Do you want to say anything since this is the last record we're ever going to have of you?
I love you.
I love you.
And I hope I will see you around here.
You're not going to see me in here, but maybe around here.